Good morning friends, welcome back. I hope all of you are doing fine. Myself is great, and today we are going to read another lecture. Myself, Dr. JIBRAN Ahmed, presents to you Simply Pathology, and today we are back with another very interesting topic, that is thrombosis part 1. So last time we had read about the basics of hemostasis, and we have discussed the role of the platelets, the role of coagulation factors, and we had also read about the role of the vessels in hemostasis. So over here we want to read about certain hemorrhagic disorders, that is disorders which manifest as bleeding. So whenever we see any hemorrhagic disorder, the problem can lie in one of the three basic pillars. Either there can be defect in the primary hemostasis, or there can be defect in the secondary hemostasis, or there can be a generalized defect which is involving these small vessels. Let us see each one of them. So whenever we are reading about, or whenever we are thinking about defects in the primary hemostasis, we always think about two things. Either there is a platelet defect or there is a von Willebrand disease, because these are the ones which are primarily involved in primary hemostasis. Now, how do such disorders present? They are going to present with minute, very small pinpoint hemorrhage. These are called as petechiae, and the size ranges from 1 to 2 millimeters only. Secondly, they can present with purpura. Okay, so purpura are slightly larger as compared to petechiae. So they are more than equal to 3 millimeter in size and less than 1 centimeter in size. Sometimes purpura can be palpable. We call it as a palpable purpura. Also, patients of primary hemostasis can present with epistaxis, that is nose bleeding, or they can present with bleeding in the gastrointestinal tract, or they can present with menorrhagia. Now, secondly, we are having defects of the secondary hemostasis. Now, as you already know that the major role in secondary hemostasis is of coagulation factor. So, all coagulation factor defects will result in disorders of secondary hemostasis. Now, in such cases, bleeding either occurs into the joints, which is called as hemarthrosis, and it is typically seen in hemophilia, or bleeding can occur into soft tissue, for example the muscle, and such localized bleeding into soft tissue is called as a hematoma. Also, very important is that intracranial hemorrhage can occur. Okay, so intracranial hemorrhage not only occurs in secondary hemostasis, but it can also occur in primary hemostasis, and when it occurs, it can also be fatal. Now, similar ICH or intracerebral hemorrhage can also occur in secondary hemostasis. Now let us read about generalized defects involving the small vessels. So these are basically composed of these patients. They present with palpable purpura, okay, and they present ecchymosis. So what are ecchymosis? Ecchymosis are those lesions which are 1 to 2 centimeter in size. So they are even larger as compared to purpura. And where are these generalized defects seen? So these are usually seen in systemic disorders. For example, we are having vasculitis. Vasculitis is what? Inflammation of the vessel. So there is a systemic inflammation of the blood vessels. Secondly, we can have vessel fragility. For example, in cases of scurvy and amyloidosis, wherein the blood vessel wall, because of defects in the abnormal protein or defects in collagen, the vessel wall is fragile and can lead to bleeding. So these are the three main types of hemorrhagic disorders, and we will read about them in details when we read about the bleeding disorders in hematology. Now let us come to today's important topic, that is thrombosis. So what is thrombosis? It is the formation of a blood clot inside a blood vessel, obstructing the blood of flow. Okay, obstructing the flow of blood or blood flow. Now, what are the primary abnormalities that leads to thrombosis? So number one, we are having endothelial injury. Second, if there is a stasis or turbulent blood flow, or we can say an abnormal flow of blood. Thirdly, if there is hypercoagulability of the blood. So what do we mean by each of them? We are going to read about them in details in individual sections. Now just remember, out of these three factors, the endothelial integrity is the most important. And also you have to remember one thing, that these factors, namely the endothelial injury, abnormal blood flow and hypercoagulability of the blood, all of them, they can promote thrombosis individually, means alone. For example, there is just endothelial injury, or there is just abnormal blood flow, or there is just hypercoagulability. So they can, okay, individually they can lead to thrombosis, or they can cause thrombosis in combination. In combination means what? Means endothelial injury is there, that is causing an abnormality of blood flow, or abnormal blood flow is causing an endothelial injury. So this is vice versa. Okay, so they can be in combination. So all these three factors can be present in any one patient, leading to thrombosis. So all these three factors, namely the endothelial injury, hypercoagulability of the blood, abnormal blood flow, they lead to thrombosis, and all these three factors are called as Virchow's triad. And Virchow's triad is a very important short note. Also, if you look in this diagram, I have shown that abnormal blood flow can cause endothelial injury, and endothelial injury itself can cause abnormal blood flow. Also, this endothelial injury can lead to hypercoagulability of the blood, and abnormal blood flow can also lead to hypercoagulability of the blood. So these factors, they can act individually or they can act in combination. Okay, let us move ahead. Now, before we go into the details of thrombosis, first of all, I want to discuss a very important concept, the basics of vascular wall response to injury. Okay, so whenever there is a vessel wall injury, it is not like there will just be thrombosis. No, thrombosis is one of the parts. So let us see in general how a blood vessel or a vascular wall will react to injury. So first of all, before we go into the details of that, first of all, we will try to understand the different layers of our vascular wall. So we are having on the innermost aspect, okay, that is surrounding the lumen of the blood vessel, is the tunica intima. It is composed of a single layer of endothelium, which is supported by a subendothelial connective tissue. Secondly, we are having just outside the tunica intima, we are having the tunica media. What is the most important thing about the tunica media? These are composed of elastic fibers and they are having smooth muscle cells. These smooth muscle cells are basically contracting and relaxing, bringing about vasoconstriction and vasodilatation. And we are having the tunica adventitia, which is mainly composed of connective tissue and is also the thickest layer, whereas the tunica intima is the thinnest layer. Now the endothelial cells, they form a single simple squamous epithelial lining for the blood vessels, okay, and endothelial cells of different parts of the body is having a distinct profile. Okay, so what are the distinct profile means? That for example, the endothelial cells lining the liver sinusoid or the renal glomerulus, okay, they are fenestrated. Okay, they are fenestrated, meaning they allow filtration of plasma, whereas the endothelial cells lining the brain, okay, which participate in the formation of the blood-brain barrier, is completely impermeable and will not allow anything to enter. Okay, so depending on the location, the endothelial cells have a different genetic profile. Okay, let us look at further. Now we will read about how a normal endothelium is, okay, or how a normal endothelium works. So if the blood pressure is normal, and if we are having a normal laminar flow, and if we are having stable growth factor levels, for example, stable levels of growth factor, for example, VEGF, vascular endothelial growth factor, okay. Now you must be thinking, what is laminar blood flow? Now I will be discussing in details about laminar blood flow, but over here, just in short, I will tell you, normal blood flow is like the blood cells and the platelets are present in the center of the blood vessel, and they do not come in contact with the endothelium. Okay, so normally this is called as the laminar flow, and this is the normal flow of blood across a normal endothelium. Okay, and whenever the pressure is normal, so whenever these three conditions are met, they are going to promote a basal endothelial cell state. And what do we mean by this basal endothelial cell state? That means our endothelium is non-thrombotic, means it is not going to promote thrombosis. It will be non-adhesive. What do I mean by non-adhesive? So as you can recall, we have read in inflammation that during inflammation, the endothelial cells express many adhesion molecules. Okay, so a normal endothelium will never express any of these adhesion molecules. Okay, so they are non-adhesive surface. Thirdly, there is an appropriate vascular wall smooth muscle tone. So whenever, remember that normal endothelium will not have an excess of vasoconstriction, neither it will have excess of vasodilatation. It is going to maintain an appropriate vascular smooth muscle tone depending on the need. And we have to remember one thing, that our endothelium, the normal endothelium, or basically the endothelium, is releasing certain factors, certain growth factors, which is controlling the contraction and relaxation of the smooth muscles, thus bringing about vasodilatation or vasoconstriction. Now, also involved in maintenance of the permeability barrier of the endothelium and growth of other cell types. Okay, so our endothelium also maintains the normal permeability, as well as it is releasing certain growth factors to support the growth of other cell types. Okay, let us move ahead. Now, what is the concept of endothelial activation, endothelial injury, or endothelial dysfunction? Remember, all these three terms are used interchangeably. Okay, so let us look at the concept of endothelial activation, injury, or dysfunction. So if you see, when I am using the term endothelial activation, so what are the factors which are going to activate the endothelium or will cause injury or will lead to endothelial dysfunction? So whenever there is a turbulent blood flow, or there is hypertension, or there is release of cytokines and chemokines during inflammation, or there are complement proteins, bacterial products, or any other infectious products, hypercholesterolemia or hyperhomocystinemia, these are the lipid products, or there is advanced glycation end products that occurs in diabetes mellitus, or there is hypoxia, acidosis, viruses, cigarette smoke. Now, cigarette smoke not directly, but there are certain toxins which are present in the cigarette smoke which can promote endothelial activation, and other inflammatory mediators. So all these factors, these are the list of factors you will have to remember. They can lead to endothelial injury or endothelial dysfunction, ultimately causing endothelial activation. So when I am using this term endothelial activation, what do I mean? I mean that the endothelial cells now have a prothrombotic tendency, that is, they have a procoagulant surface. They want to promote the process of clotting, the process of formation of platelet plug, the process of formation of activation of the coagulation cascade. So endothelial surface, now they are having a procoagulant or prothrombotic surface or tendency. Secondly, in response to inflammation, as we have seen, the endothelial cells, they increase the expression of adhesion molecules, as you will remember, the P-selectins, the E-selectins, if you can remember, okay, and the ligands for the integrins. These are the adhesion molecules. So there is an increased expression of adhesion molecule which is going to attract the inflammatory cells. And thirdly, they express factors that is going to cause smooth muscle contraction, proliferation, and increased amount of extracellular matrix synthesis. Now, all these three changes that we have seen in our last point, you will remember all these changes are part of a normal healing process, and our endothelial cells are no different than any other cell in our body. Okay, so there is proliferation of smooth muscles and extracellular matrix synthesis, and this is having a important clinical impact. We are going to read about it in the next slide. So whenever there is an endothelial dysfunction or injury or activation, it predisposes the vessel to thrombosis, atherosclerosis, and can lead to the vascular lesions of hypertension, namely, as you can remember, hyaline arteriosclerosis and hyperplastic vascular lesions, okay, of hypertension. So these are the few important changes that can take place with endothelial dysfunction. Now, remember, endothelial dysfunction can sometimes be reversible. So sometimes the endothelial dysfunction, they are rapid in onset, okay, within minutes, and they are reversible. For example, endothelial cell contraction induced by histamine, which increases the vascular permeability, as you will recall. Now, coming to a very, very important concept is the intimal thickening response to the vascular injury. So according to this theory, in short, what they are saying, that whenever there is a vascular injury, okay, the vessels are going to respond, okay, and they are responding by increasing the smooth muscle cell proliferation and extracellular matrix synthesis, which is going to increase the thickness of the intimal layer of the vessel. That will ultimately lead to narrowing of the vessel and sometimes can cause vascular obstruction. So whenever there is a vascular injury or dysfunction or loss, the smooth muscle cells from the tunica media or the circulating precursors, they are going to travel and migrate into the tunica intima. Now once these smooth muscle cells have entered the tunica intima, these start to proliferate and they start to synthesize extracellular matrix, and these are classically non-contractile. Remember, the smooth muscle cells which are belonging to the tunica media are different from the ones which are present in the intimal smooth muscle cells. Okay, their properties are different. If you can remember, the smooth muscle cells of the tunica media are responsible for vasoconstriction and vasodilatation, whereas the smooth muscle cells inside the tunica intima, they are proliferative. So they proliferate, they synthesize the extracellular matrix, and they are non-contractile. So these three properties of intimal smooth muscle cells are quite distinct from that of the media or medial smooth muscle cells, and because of this response to vascular injury and because of an ultimate intimal thickening, it can lead to vascular obstruction. Okay, hope you have understood till here. Let us move ahead. Now we are going to see the basic important parts of thrombosis. The first important contributing factor towards thrombosis is endothelial injury. So let's see what happens during endothelial injury. So whenever there is an endothelial injury at the level of the heart or at the level of arterial circulation or in the arteries, there is a formation of a thrombus, but this thrombus is rich in platelets. Now you will ask me a question, why is like this, sir? Because of high rate of blood flow in the arterial circulation and in the heart, there is no clot formation, means there is just primary hemostasis. Secondary hemostasis cannot occur. Okay, so therefore just the primary platelet plug is formed. The secondary clot, the definitive hemostatic plug, which is composed of clotting factors, that is our coagulation factors, cannot be formed because the rate of blood flow inside the arteries is very high. Okay, so there is no clot formation. Therefore we can say that cardiac as well as arterial thrombus or clots are typically rich in platelets. Okay, there are very less coagulation factors, but they are more rich in the platelets. So there is an important clinical aspect to it. So platelet activation is a necessary requisite for thrombus formation under high stress condition. High stress means under high speed of blood flow. Where the speed of blood flow is very high, there will just thrombus formation will just take place by the formation of primary platelet plug, just by platelet activation. So we can say that platelet activation is a necessary prerequisite for thrombus formation under a very high stress condition. Example, arterial circulation. Now here is the clinical aspect. This explains the use of antiplatelet drugs, for example aspirin and other inhibitors, platelet inhibitors, in coronary artery disease and in case of myocardial infarction. Okay, now we have already seen this next point, that what are the stimulus which causes endothelial activation, dysfunction, injury or a prothrombotic state. So we have already seen these points: the inflammation, physical trauma, infections, toxins in cigarette smoke, hypercholesterolemia, hyperhomocystinemia, abnormality of the blood flow. All of these factors can lead to endothelial cell activation or dysfunction or a prothrombotic state, and I have already mentioned what endothelial activation means. Okay. Moving ahead, now my question is, you should ask me how endothelial activation or dysfunction is creating a prothrombotic state. So there are two answers to it. One is, it is causing procoagulant changes. So once there is a procoagulant change, okay, this occurs because of the down regulation of expression of certain factors like thrombomodulin, protein C and tissue factor pathway inhibitor. If you have seen my previous lectures, you will know that all these three factors are responsible for the anti-thrombotic activity of the endothelium. But if the endothelium is activated, all these three factors, the levels of all these three factors will come down, and this will create procoagulant or prothrombotic changes. The second important point is that endothelium normally has an anti-fibrinolytic effect, but activated endothelial cells is going to secrete plasminogen activator inhibitor, that is PIEs, which is going to inhibit tissue plasminogen activator. So if you have read my previous lecture and if you have read hemostasis, you will recall that normally our clotting formation or coagulation cascade is limited to the site of injury by fibrinolysis. Okay, and this is true after every or any kind of injury, okay, whereas there is fibrinolysis. But once the endothelium becomes activated, injured, or there is a dysfunction, there will be anti-fibrinolytic effect, okay, and both these effect is going to lead ultimately to thrombosis. Okay, now the second important leg of thrombosis is abnormality of the flow of blood, where the blood flow becomes abnormal. So let us see over here. Before we go into this part, we have to understand what is a normal laminar flow. So in a normal laminar flow, by saying this, we mean that the platelets and all the other blood cells, namely the red cells, the white blood cells, all of them, they are at the center. Okay, and in the periphery we are having the slower moving plasma. Okay, so why our normal blood flow is laminar? So as to prevent any contact between these platelets and the endothelium, and so as to prevent endothelial activation. Okay, so this is how a normal laminar flow prevents thrombosis in a normal endothelium. Now let's see what happens during turbulence. So whenever there is an abnormal blood flow or turbulence, there can be endothelial dysfunction or injury directly, and this will lead to the formation of an arterial and cardiac thrombus. Whereas sometimes turbulence can lead to counter currents, okay, which will produce local pockets of stasis. So stasis का मतलब क्या है? What is the meaning of stasis? Stasis mean a basic area, a basic place where the blood has stopped flowing and it is just present. It is just still and standing. So whenever there is creation of local pockets of stasis, it will ultimately lead to formation of a venous thrombus. Okay, venous thrombus. Now moving ahead. Now turbulence and stasis, let us read about them, how they create thrombosis. First of all, they are going to disrupt the normal laminar flow, and this will bring the platelets in contact with the endothelium and will ultimately lead to endothelial activation. Secondly, they can directly cause endothelial activation. How? Now flow-induced changes in the endothelium causes expression of certain adhesion molecules, thereby producing a pro-inflammatory state and also increased pro-coagulant effect. And thirdly, turbulence and stasis, mainly the stasis part, they prevent the washout of and dilution of the activated clotting factors. So whichever activated clotting factors were there, they are not allowed to go away. They are not allowed to get diluted because there is no fresh flow of blood. There is no flow of blood over there. Because of that, all these activated coagulation factors is going to accumulate at the site of injury or activation, and that is going to promote thrombosis. Okay. Now moving ahead, now we are going to see certain examples of abnormal blood flow. Number one is the atherosclerotic plaque. Okay, so once the atherosclerotic plaque becomes ulcerated, it is going to expose the subendothelial collagen and the von Willebrand factor. This together with turbulence will promote thrombosis. Second is, together with turbulence is going to promote thrombosis. Second is the aortic and the arterial dilatation. So whenever there is a dilatation of the arteries or the aorta, we call it as an aneurysm, and once this aneurysm is created, it will lead to local stasis, and once the local stasis is there, that will cause thrombosis. Moving ahead, the third important example is acute myocardial infarction. So whenever there is an acute myocardial infarction, there are areas of non-contractile myocardium and there is cardiac aneurysm. Both these conditions is going to produce areas of a stasis, which is going to cause thrombosis. Next example is the rheumatic mitral valve disease or stenosis. Now what happens over here? The left atrial dilatation will occur because of mitral stenosis. Okay, the left atrium will dilate and it can also lead to atrial fibrillation. Again, there are areas of a stasis which will lead to thrombosis. Now the fifth point is hyperviscosity, as it is seen in a hematological disorder called as polycythemia vera. What happens in polycythemia vera? Our blood becomes very thick. Okay, there is panmyelosis, there is increased in the levels of all three lineages. Okay, RBCs, WBCs and platelets, all of them increase in quantity and amount. So what happens that in this condition there is a resistance to the flow of blood, and which causes a small vessel stasis leading to thrombosis. And the fifth and the sixth important cause is sickle cell anemia. Again, this is a hemolytic anemia wherein the deformed red blood cells will impede, or that was going to prevent the flow of blood, ultimately leading to stasis and thrombosis. Now moving ahead, the third important leg is hypercoagulability of the blood, a very, very important part which contributes to thrombosis. Now hypercoagulability refers to an abnormally high tendency of the blood to clot and is typically caused by alterations in the coagulation factors. Now, the causes of hypercoagulability can be primary or genetic or inherited, and it can be secondary acquired disorders. So what are the common causes of both? Let us see. So one is primary, one is secondary or acquired. Now the common causes of primary or inherited hypercoagulability are factor number 5 Leiden mutation, prothrombin mutation, these two forming the most common inherited causes. Then increased levels of factor number 8, 11, 9 and fibrinogen. Now what are some of the rare inherited causes? Antithrombin, protein C and protein S deficiency. And last, which is very rare, are the fibrinolysis defect and homozygous homocystinuria. Now, among the acquired causes, there are certain strong risk factors. For example, prolonged bed rest will promote hypercoagulability, immobilization, myocardial infarction, atrial fibrillation, disseminated intravascular coagulation or DIC, cancers, surgery, burns, fractures, HIT syndrome, that is heparin induced thrombocytopenia, and APLA syndrome, that is antiphospholipid antibody syndrome, and prosthetic valves. What are the other risk factors? Other risk factors are cardiomyopathy, nephrotic syndrome, hyperestrogenic state, oral contraceptive pills, sickle cell anemia, and smoking. Now, we are going to read about some of the important inherited causes of hypercoagulability. The first is factor number 5 Leiden mutation. This is characterized by a single nucleotide mutation in factor number 5, also known as factor number 5 Leiden mutation. And this mutation is going to make the factor number 5 resistant to cleavage and inactivation by the protein C. Now here in this mutation, there is a single arginine to glutamine substitution in the amino acid residue 506. Now this is an autosomal dominant disorder. Now if the state is homozygous, then there is a 50-fold risk of thrombosis, but if it is heterozygous, there is a 5-fold risk. Just remember one thing, homozygous and what is heterozygous, we are going to see in details in the chapter on genetics. Just now you can understand one thing, that homozygous conditions, okay, and heterozygous conditions. So homozygous conditions are more severe as compared to heterozygous condition, okay, and the details of which we are going to explain in chapter on genetics. The basic clinical feature is the recurrent thrombosis, that is DVT. And just remember one thing, that patients who are presenting with recurrent thrombosis, among them the frequency of factor number 5 Leiden mutation is around 60%, okay. Moving ahead, the second most important or common inherited defect is prothrombin gene mutation. Now here there is a single nucleotide chain, okay, G20210A position in 3' untranslated region or UTR region of the prothrombin gene. So whatever the mutation is over here, it leads to an increased prothrombin levels. There is a 3-fold increased risk of venous thrombosis. Now other rare causes are antithrombin 3 deficiency, protein C or protein S deficiency, and this deficiency will lead to thrombosis. Now homocystinemia, now increased homocysteine levels, okay, can occur because of inherited deficiency or because of acquired deficiency. So among inherited deficiencies we are having deficiency of cystathione beta synthetase, and among acquired disorders we are having deficiency of B6, B12 and folic acid. Now the prothrombotic effect of homocysteine is due to the thioester linkage between the homocysteine and fibrinogen. Moving ahead, now we have already discussed the inherited, among the inherited causes, we have to discuss few things, that factor number 5 Leiden mutation and G2210A prothrombin variant, they are most common among the inherited causes. Now there are heterozygous variants and there are homozygous variants. As I already told you that all these inherited causes can have a heterozygous variant, can have a homozygous variant. And as I told you, heterozygous variants are less severe as compared to homozygous variants, and the details of which I will discuss in the chapter on genetics. Now remember, the heterozygous variant, they are free of any thrombotic complications usually. But if there is associated acquired factors, for example, prolonged airplane travel, prolonged immobilization or inactivity, okay, then the risk is going to increase. And also you have to remember one thing, that and therefore any patient who are less than 50 years of age and is presenting with thrombosis, you have to rule out any inherited causes even if acquired causes are present. Why? Because most of them are heterozygous variants and they are free of any thrombotic complication. Okay, even if they are associated with some acquired factors, then and only then they are going to present. So even in presence of acquired risk factors, you should search for any inherited causes in case of heterozygous variant. In homozygous variants, remember, the patient will present with thrombosis and they are having a greater risk of thrombotic complications even in the absence of acquired risk factors. Okay, now among the acquired causes, oral contraceptive pills or hyperestrogenic state in pregnancy, they pose an increased risk for hypercoagulability. Why? Because of an increased hepatic synthesis of coagulation factors and reduced anticoagulant synthesis. Also, in case of disseminated cancers, there is release of procoagulants from the tumor which predisposes to thrombosis. Okay, with advancing age, there is a decreased amount of prostacyclin production which also predisposes to thrombosis, and smoking and obesity increases hypercoagulability by unknown mechanism. Thank you very much guys for watching this video. Please subscribe to my channel and please share with those in need. If you have any doubts, please do comment. Thank you very much. Stay tuned for more lectures.